All right, let's get started. Hello, and thank you for joining the POCUS Certification Academy for today's webinar. My name is Daria, and I will be your webinar host for today. The webinar is now beginning, so all lines have been muted. Please use the Q&A box for any questions or the chat box for comments you have throughout the webinar. And today's topic is POCUS Transvaginal Scanning Review, and our speaker is Victor Rao. Dr. Victor Rao is a radiologist by training and worked as a primary care physician before pursuing radiology. He's one of the pioneers to introduce point-of-care ultrasound to medical students and PA students at the University of South Carolina School of Medicine. He developed the POCUS curriculum and POCUS educational content for physicians and PA students at the USC School of Medicine. He also helped develop the e-learning YouTube content for USC School of Medicine, as well as develop the teaching content for Introduction to Point-of-Care Ultrasound CME program. His passion is ultrasound and POCUS. He also helped introduce POCUS at Arusha Lutheran Medical Center in Tanzania, the University of Santo Tomas in Manila, Philippines, and Haiti. He has authored and co-authored several ultrasound and high-intensity focused ultrasound articles published in peer-reviewed journals. He's written several chapters at the point-of-care ultrasound textbook, blog articles, and clinical cases. His goal is to teach POCUS and make it easy for clinicians to learn and practice safely and effectively. He has trained thousands of students and clinicians in hands-on point-of-care ultrasound and also is part of our team. Please welcome our speaker today, Victor. Thank you, Vic, for taking your time today. We're very excited.
Thank you, everyone, and welcome, everyone. I hope you guys can hear me clear. So today's topic is Introduction to Transvaginal Ultrasound. And as Daria pointed out, my name is Victor Rao. You can call me Vic. And ultrasound is my passion. And transvaginal ultrasound is a little bit tricky topic, but we will try to make it very simple and easy for everybody. And this is going to be an add-on to the lecture and training that I've already received on transabdominal ultrasound for the pelvic region and for evaluation of pregnancy. So today's learning objectives are going to be what exactly is transvaginal ultrasound? Why do we even need to do a transvaginal ultrasound? And then how it is performed, what are the prerequisites, a brief overview of the pelvic anatomy on the basis of how you would look at it from transvaginal ultrasound images, and then how to position the patient, how to do the probe orientation and transducer preparation, procedure by itself, and the image and transducer orientation. Those are very important to understand to get it right, and how to disinfect and clean the transducer after every procedure. So you have to disinfect the probe properly after every procedure, and we will go through it in detail. And important points to remember: some basic pelvic ultrasound in a non-pregnant patient, as well as in first trimester. Of course, what everybody was really keen on learning was ectopic pregnancy. And then also another condition that you must know is called heterotopic pregnancy. We're going to review all of these with cases and also test your knowledge at the end of it. So what exactly is transvaginal ultrasound? As you can see in this image, we essentially introduce the ultrasound transducer into the vagina to kind of come very close to the cervix, or almost touching it, and we scan the region inside over here. Keep in mind that it is a high-frequency transducer, and since there is no bowel gas involved over here, you may see a little bit of the bladder. We want the bladder to be kind of empty or a little bit urine in there. And posteriorly, of course, you see the bowel here, and so the rectum. And you're essentially very, very close. And so because we are so close, we can use a high-frequency transducer and get really high-resolution images. I will show you some images shortly so you can understand what we're talking about. But why do we even want to do a transvaginal ultrasound? We want to do the transvaginal ultrasound because sometimes the anatomy and the pathology is just not clearly seen. And sometimes we want to confirm a diagnosis, especially in ectopic. I want to confirm an ultrasound diagnosis that is really there or not. And then keep in mind that because you use high frequency transducer, it's in the range of 5 to 12 megahertz. So the image quality is a really, really very good high resolution images. And so the patient images have better spatial axial resolution. And also another advantage of this probe is that it has a very wide field of view. So here are some two diagrams kind of showing you how we would scan transabdomen, which I believe you already have been trained in and you are already doing it. So we put the probe in the patient's lower abdomen and the pelvic region above the pubic symphysis, and you see how a distance it has to travel. It's traveling through the bladder into the uterus. So it's quite distance, and because the ultrasound has to travel such a long distance, so we cannot use high frequency transducer. So we have to use a low frequency like 3.5 mega typically, and that allows the ultrasound beam to travel deep and to be able to image the pelvic organs. Whereas in comparison, you can see the transvaginal ultrasound has one advantage. We are coming just in direct contact with the cervix. And so therefore, we can use high because there's no distance to travel, as in this case over here. The distance is very short. So image quality is going to be much better because there's no obstruction and very high frequency is being utilized. I can say about this all day, but the pictures are going to tell you the whole story here. So you can see this is a case of ectopic pregnancy. And here's a view on the transabdominal view. You can see we have to fill the bladder up in this case because the bladder will allow ultrasound beam to travel through the uterus. And it's known as an acoustic window. It allows unobstructed view. Otherwise, there will be bowel gas here, and you may not be able to see anything. But look at this image. This is a uterus, of course. You can tell there's a uterus. You can see the endometrium. And if you look, we don't see any free fluid around here, but we see a small suspicious area, which turned out to be an ectopic pregnancy. I can't really make a definitive diagnosis on transabdominal, but I can tell that there's something suspicious. And at times, you may not even see this. But on this side, we see a transvaginal ultrasound being performed. We can see the uterus. We can see the endometrial stripe. We can see the endometrial layer. We can see the myometrium so clearly. We can also see outside the uterus, we can see an embryo. So this is an ectopic pregnancy. And you can tell the difference right away. How much difference would you prefer this or would you prefer this? Of course, we want to do a transabdominal first and then follow that by that. We're going to do a transvaginal and we can definitely come to a conclusive diagnosis, and this patient would require surgical correction. So just common indications. Ectopic pregnancy, of course, is one of the indications. And also heterotopic pregnancy, but there could be other things. We like to look at the female pelvic organs in great detail. There could be ovarian cysts, ovarian cancer. There could be uterine pathology with fibroids, or there could be polyps inside. There could be endometrial carcinoma. We have endometriosis, hydrosalpinx. The fallopian tubes are dilated and they're full of fluid or pus. IUD, intrauterine device localization. You may have inserted a device and you're not so sure where it is, or you want to confirm its location. Early pregnancy evaluation, as you know, it's a transvaginal ultrasound has high frequency, so we're able to see much more detail of the embryo and also document cardiac activity. Even yolk sac can be seen. Early pregnancy failure, if you're suspecting the patient has pregnancy failure, then you may want to do a transvaginal ultrasound. And short cervix, incompetent cervix, all these are great indications. By the way, these are not the complete list, but these are the common indications. So one question that I commonly ask is that should we only do a transvaginal ultrasound? And the answer to that is no. We don't want to do transvaginal ultrasound only. We always pair a transabdominal pelvic ultrasound with transvaginal. And the reason for that is the transabdominal gives a wide field of view, more coverage. We can see a lot more. The image resolution is not great, but we have a much more wider field of view. We can look at other organs also in the abdomen. In the transabdominal approach, we get a longitudinal and transverse view of the uterus. But when we do a transvaginal approach, we get longitudinal or the sagittal view and coronal view. So just a little different plane of cut, and we will understand better as we go through the slides. So what are the prerequisites of performing the transvaginal ultrasound? Always obtain written consent. Explain the procedure to the patient. The patient will be anxious, not wondering what's going to happen. And so explain the patient. If there is a male clinician performing, must have a female chaperone present throughout the entire procedure. And I would actually also have trained a female chaperone to insert the transducer for the patient and request the patient to empty the bladder before scanning, because if the bladder is full, you may not be able to see structures clearly. It may come in the way. How much time would it take to perform transvaginal ultrasound? I would say in the beginning for you guys, it'll take maybe 30 to 45 minutes. And as you get better at doing this, you will probably get maybe 15 minutes, in 10 minutes even, as possible. Patient may experience slight discomfort. If the patient has an infective condition, then obviously may have a little bit more discomfort or engorged pelvic vessels that can also create a lot of pain. But other than that, when you're doing the routine ultrasound, most of the patients have never really experienced too much discomfort. And always explain the patient what you're going to do, because patient will definitely appreciate that. So here's the basic anatomy. We're not going to talk about a lot of the structures. We're just going to focus on the bladder and the uterus. So you can see anterior to posterior, we have the bladder, and then posteriorly we have the uterus. And of course, we have the fallopian tubes, which may or not be seen on transabdominal ultrasound unless they are dilated. There's some parts of fluid inside it, yes. And then you can see the ovaries on either side. And here is a little bit, I created this view, a little bit on the side, oblique view. You can see the bladder, and posterior to the bladder, we have the uterus, and here's the vagina. So you can see how the probe is going to be inserted into the vaginal canal right here. And we are coming very, very close to the cervix, and we are looking through the cervix and into the uterus and into the pelvic organs and the adnexa. Here's a view, transabdominal view, to kind of show you. This is the bladder. Here's the uterus. Here's the cervix, and this is the vagina. So we must have seen some images that show vaginal stripe. So this is essentially the probe is inserted in the vagina, and then posterior to the uterus, we have the space. This is the potential space. Normally, we don't see anything, but in this case, we see a little bit of fluid. And keep in mind, simply fluid there doesn't mean much. It could be physiological. One time, I remember we were scanning a patient, and as we were scanning the patient's follicle rupture, and then we suddenly see a little bit of fluid coming here. So this could be physiological. So don't think that this is always going to be ectopic. So one thing that we need to understand is the uterus is varied in position from patient to patient. We have anteverted or retroverted. This is a transabdominal view. You can see that this is a vaginal stripe. And if we put a probe in this way, we're going to put the probe, and here is cervix. And when you say anteverted, it simply means in relation to the vaginal stripe, the cervix or cervical canal or cervix is pointed anteriorly towards the ceiling. And in retroverted, we have the vaginal stripe like this, and its cervical canal is kind of pointing backwards or posteriorly. Here it is on the transvaginal ultrasound. We see anteverted uterus, very different orientation. So you just have to get used to it. So this is where the probe is touching the patient inside the vagina, and we are looking into the uterus, and you can see this is your endometrial stripe, and this is the endometrium, And of course, this is the myometrium. And here's a retroverted uterus. We can see it's kind of pointing backward now, posteriorly. So, but this can get confusing. So I'm going to draw some more images for you. And here's a sagittal view. We can see this is the ultrasound beam. It is cutting through the bladder and also into the uterus. So the probe marker is very important. Every probe, as you know, has a probe marker. When we do a sagittal view, like in this case, the probe marker is going to be pointing towards the ceiling, up to the ceiling. And when we do the other view, so look at this. This is the probe marker pointing up to the ceiling. And this is the view. Normally, I kind of put this view like this. Ideally, this is what the image really is. But when we look at the transvaginal ultrasound image, we don't really see the image like this. So we see it very differently. So we basically take the image and then we flip it. So about 90 degrees, and let's look at it, how it will look like. So this is the image that is being formed. But when we represent it on the ultrasound screen, we show it like this. So this is where the probe is, probe head, or the probe footprint, and the transvaginal probe is over here. And you can see this, the uterus is represented like this. So it's kind of a little confusing, but with time, you will get better. And so here it is, a retroverted uterus, and it's kind of like this actually. But when we represent it in the ultrasound monitor, we represent like this. So we basically take this image and we kind of flip it 90 degrees counterclockwise. So it starts looking like this. So this is something that you'll have to get familiar. I would recommend you draw this so that you are very familiar with it. As I pointed earlier, that we have to be familiar with the cul-de-sac or the pouch of Douglas. Why? Because it is the region behind the uterus and where it's the most dependent. So if there is any fluid, any blood in this area, it would gravitate and collect over here. As you can see in this patient has a little bit of free fluid in the pouch of Douglas. So this is where it's going to collect. Obviously, if the volume is large, then you will see it's going to fill up all this space and go even higher. So the uterus position in the horizontal plane, that is important to understand because sometimes the uterus is not really sitting exactly in the midline. It could be shifted a little bit to the right or to the left side of the patient. And obviously we have anteverted, which is the most common position of the angulation of the uterus, and could be retroverted as well. So let's look at this probe image orientation marker. On your probe, you'll see it's over here. And this marker corresponds to this marker on the ultrasound image. So when you're doing general imaging and transvaginal ultrasound or even abdominal ultrasound, the image orientation marker is going to be on the left-hand side. And this marker corresponds to this. So that is so important to understand. And therefore, when you scan, if you point this away or towards the posteriorly, then obviously the entire image will be flipped. You'll see the uterus pointing the other way. So make sure when you're scanning that you're fully aware where the image or the probe orientation marker is. And when we're doing a sagittal scan or the longitudinal scan, we always have it pointing to the ceiling in the room. So one thing that comes to mind is how do we prepare the transvaginal transducer? We do not insert the transvaginal transducer in the patient without properly prepping it. So take ultrasound gel. It could be regular ultrasound gel. And we put a lot of gel on the footprint of the transducer. And once you see there's lots of gel, we then put a condom or we put a probe sheet on it, which is designed for transvaginal ultrasound. And make sure there's no air trapped over here. Air will make the image look bright. You'll see a bright area with black dead zone, or not that, but black acoustic shadow. So we don't want that, and make sure that there's no black zone over there. And then we can also put a little bit of specialized, like not regular gel, but a sterile ultrasound gel or a sterile lubricant outside the sheath to provide a little bit of lubrication before inserting that transducer into the patient. Please do not use this gel because this is not sterile for that application and can cause infection. So we definitely don't want to use this unless you have a sterile. And at times, you may not even need this. I will tell you that since I was performing thousands of ultrasound transducer scans, I never did feel the need to put a lubricant. And so it's totally up to you. If you want to do that, you can definitely use it. So this is how I would have the patient lie on the table. Patient lie comfortably, probe is inserted. We explain the patient, proceed to the patient, got a consent, and no need to uncover the patient, have the patient draped properly. That's going to make your patient very comfortable and relaxed. Tell the patient to relax, and you can perform the scan. Some folks actually put the patient's legs on stirrups, which to me is a very uncomfortable position and is not needed. I have never performed a transvaginal ultrasound with the patient on stirrups. But it's your choice. You can decide what you want to do. But I think both are okay, but I felt there was no need to put the patient's legs on the stirrup because every patient I talked to about the scans done that way told me that they felt very uncomfortable. So we definitely don't want to do that. But I'll let you guys decide. So once we're going to go over the procedure. Once the patient is properly positioned, we're going to proceed as follows. The transvaginal probe is inserted gently into the vaginal gland. While you're watching the monitor, you don't have to look at the patient. You look at the monitor and have your probe marker pointing up to the ceiling. We call it the 12 o'clock and your wall clock. If you have a clock, the 12 o'clock position, we point probe upwards, the probe marker up to the ceiling, and insert the transducer while you're watching the monitor. And as you insert the probe, you start seeing the cervix, you see a little bit of the bladder. If you see the bladder is really full, that means this is not going to be a good scan. So you want to tell the patient, well, your bladder is full. We need to send you back to the bathroom. And then they pee and come back, and then that's a good position to start scanning again. So once you identify the uterus, then you look at entire structure. So you move the probe, angulate it more to the right and to the left until you don't see the uterus anymore. Look at adnexa, look at the ovaries, examine the ovaries, and that's really what you're going to be doing. And once you have enough imaging done of the uterus and the other structures in the longitudinal or the coronal plane or on the sagittal plane, then we're going to turn the probe 90 degrees counterclockwise. Now it should point to the 9 o'clock position. And why it's important? Because now the probe marker is going to point to the patient's right side and examine the uterus and the cervix as the ovaries and adnexal structures and look for any abnormality. Now we will go over transvaginal ultrasound probe orientation and the image orientation, how they are connected. First, we need to review the two approaches. We can examine the pelvic region in the transabdominal approach, and we can also do a transvaginal. So transabdominal, you're very familiar with. We put the probe on the patient's lower abdomen in the pelvic region, and we obtain a sagittal view and the transverse view. In the intracavitary or the transvaginal approach, we insert the probe into the patient's vagina, and then we get our saddle view, and then we turn the probe 90 degrees, the probe marker pointing to the patient's right side, and then we get a coronal view. So let's look at the images here. This is the probe inside the vagina, and we are cutting through the uterus right here. And so remember, this orientation will guide you what the probe, where the probe is and where the images are looking at, which is anterior, which is posterior. You can clearly tell this is obviously anterior abdominal wall, so this is anterior, and this is posterior towards the back, and this is going to be the cephalad towards the head region. Probe marker is pointing to the ceiling, and this probe marker is corresponding to this marker on the screen. So this marker will always stay the same. And look at it, how we have flipped the image, and we are kind of seeing it like this. And this is where your probe is touching the patient. And so you're scanning and you see the endometrium, you see the myometrium, we see the pouch of Douglas. This, by the way, is not a real image because this was obtained on a simulator, like a phantom. So it may not be a good representation, but it's good for training. So if I angulate my probe more posteriorly, then obviously, so keep in mind, you have to be aware where your probe is pointing and where you're angulating it. If you put anteriorly or posteriorly or straight to the head region or cephalad, then you have to kind of orient yourself accordingly, but you can all agree here. So this is the posterior region. So we have pouch of Douglas here, or the cul-de-sac. We can see some bowel with, some bowel gas in it. The white is the bowel gas, some shadowing. And of course, a little bit of the bladder. The bladder was emptied out. And so this orientation is so important for you guys to understand. The coronal view is different from the other scanning that we did on the transabdominal scans, that we are actually getting a coronal view now, which is cutting across at the horizontal level from right to left. And we can see this is a representation here. So this is the right side of the patient. And the probe marker is, as I said, point to the patient's, not your right side, the patient's right side. So this is point to the right, and this corresponds to this. So therefore, this is representing the right side of the patient, left side of the patient. Why it's important? Because when you orient it correctly, once you orient the probe correctly, probe marker point to the patient's right side, and we do a coronal view. So if I see a mass over there, I say, there's a mass seen on the right side of the patient, or if it's on the ovary, you say this is the right ovary. If it's on this side, then you see the left ovary. So this is anterior and this posterior. But this will vary a lot because depending on if it's anteverted, anteflexed, the uterus is like pointing up like that, then it's different. But if you have the uterus straight out, then it would be different. So this will come with experience. As you do more ultrasound, you will get familiar with it. So make sure that you note where the probe footprint is pointing and also the orientation of the uterus in the transabdominal ultrasound view that you just did before this procedure. So once you're done the procedure, we withdraw the transducer and we do high-level disinfection. This is very different from your transabdominal ultrasound because that just required a low-level disinfection. That means you just clean the probe and wipe it with a, some approved disinfectant agent. But this is high level. That means it will undergo a more detailed cleaning procedure. So we remove the probe sheet, dispose it properly, and we clean the probe. We can use running tap. That's what I would do, the running tap water, and to remove the extra gel that's on there, clean it with a soft cloth. And we definitely want to rinse the probe with running water and cloth and wipe it with the cloth, and so it's dry. And then after that, we do a high-level disinfection. This is mandatory, by the way. And the reason it's mandatory because you do not want to transmit infection from one patient to the next. You don't want to do that. What if a lot of time patients got HPV from another patient while they underwent a transvaginal ultrasound? That is not acceptable. So for that reason, we have some specified agents that are allowed for doing this and approved. This chemical disinfectant. We do glutathione-based solutions, and there's hydrogen peroxide. There's automated systems also, which use UV light, CUV, or it could be hydrogen peroxide vapor systems. And you must follow the instructions of your device manufacturer as well as the device or the system or the chemical that you're using, because they may say, dip the probe for 10 minutes in the solution. So you cannot bypass that. You must dip it for 10 minutes. You cannot do it 1 minute and hope that it is disinfected. Even though we cover the probe with a sheet or a condom or something, we must do proper disinfection because We owe it to ourselves and to our patients. We do not want to transmit infection from one patient to the other. So important points to remember before doing the procedure is explain the procedure to the patient. A patient will ask you, is it going to be painful? No, it's not going to be painful. Just relax, just be okay. And obtain written consent. Have a female chaperone present during the entirety of the scan, and always empty the bladder. And remember the probe orientation. So remember probe marker pointing cephalad or to the, not cephalad, to the ceiling when you're doing the sagittal view, and then turn it 90 degrees counterclockwise so that the probe marker now points to the patient's right side when you're doing a coronal view. We got lucky because recently a group of radiologists, experienced radiologists got together and they developed this paper and published it. And so I will share the link with everybody, and I also put some over here, because as you do this, you can use as a gold standard, because you want to do things right. You want to use the right terminology. You want to make sure everything is done right. So this is going to be very helpful. And I have links to it, to the article towards the end. So we definitely encourage everybody to download it and review it thoroughly, not once, but many times as you're doing this, and also can be a reference guide for everybody as you're doing transvaginal scans. There's another term that comes to mind we call, early pregnancy loss. That is the one that is accepted now, and we don't want to use any other terminology. So this also added in there, and it's also in the article. We must review it and look at it. So now this is the hot topic that everybody is wanting to talk about, is the ectopic pregnancy. So what really is ectopic? It's going to be eye-opener for everybody. Ectopic is not mean it's simply outside. It could be still within the uterus. So these are the two normal locations. We have intrauterine and slightly eccentric, as you can see. If it's towards the fundus or very close to the fundus in the half of the uterus right here, then this is considered normal, okay? A and B are normal. If it's in the cervix, that is not considered normal. So this is ectopic, by the way, still inside the cervical canal, but this is ectopic. Here we have cesarean scar pregnancy. This is also considered ectopic, and it could be within the intramural region, over here. And this is also abnormal location. It could be interstitial, where the tubes are coming in. So this, all abnormal locations could be, this is the most common you'll see, is going to be in the fallopian tube. This obviously is not going to be able to support the pregnancy. It could be inside the uterus. Inside the ovary. So this is ovarian pregnancy, rare, but you must be able to look at it and identify that. It could be in the abdomen. I have some two very interesting cases for you guys. You'll be shocked how it is so surprising for anybody to even imagine that is even possible. So let's look at this. This is obviously still within the uterus, but it is considered ectopic, and this is actually in the cesarean scar. So take a history of your patient and also examine the abdomen. Patients sometimes don't remember that they had a cesarean section. And so just look at the uterus and divide not the cervix, but divide the uterus into two halves like this. If it's in the upper half, that is normal, okay? If in the lower half, that obviously abnormal, and then you can see in this case, the patient had a cesarean section, and this is ectopic cesarean scar pregnancy. So in ectopic, we will see certain things. This I've added in there. This is again from that other article, the lexicon article by radiologists. So it's a gold standard, and it was just published in 2024. So you must look at this. And so you could see you can see in the fallopian tube or in the lower, over here, and the lower section. And this is cesarean scar pregnancy. We have it X-ray or adnexal mass. The ectopic might look like adnexal mass. These are all these images are transvaginal. So you can see you must learn transvaginal, and you must perform transvaginal in patients whom you suspect pregnancy, early pregnancy, or ectopic pregnancy. Here we have a tubal ring, and then, this one is, you can see the uterus is empty. There's nothing in there, but the patient has urine HCG positive, so the patient is pregnant. So where is the pregnancy? And therefore, you want to look at the location of the pregnancy, which obviously is ectopic. So remember certain things, we want to look at the whole picture. And obviously urine test is positive, and abnormal beta HCG levels, it would be lower than what we would expect for the gestational age. So in ectopic, the HCG levels seem to be a little lower, and patient may have symptoms, pain, pelvic pain, abdominal pain. It could be vaginal bleeding, dizziness, weakness, low blood pressure. Patient is unconscious. A lot of my patients that I have diagnosed ectopic were unconscious. They had no palpable pulse and no recorded blood pressure. And so, young patient just got married and comes in like that. What is first thing on your mind? Ectopic. You want to rule it out. Why would suddenly the blood pressure drop? Because the blood is leaking inside. There's hemorrhage happening inside. So we want to do the ultrasound immediately without delay and diagnose. And if needed, we do a transvaginal. And we diagnose the ectopic and rush the patient to the OR. And we save a bunch of lives like that, because that's what we were thinking. And we didn't waste even a second. And we went ahead and did the procedure right away. And by the way, all the patients survived. So that's a good thing. There is another thing that to be aware of is terms like heterotopic pregnancy, spontaneous complete abortion, and also very early interest. So sometimes it is positive and you do the ultrasound, you don't see it's a very early pregnancy. So if you don't see a topic, you don't see blood loss, any evidence of blood loss. So obviously, you need to follow the patient up after 1 week and try to scan, and also do the beta HCG levels if you have them available in your lab, and to see are the values rising or not. So those are important things to understand. The good news is that most of the ectopic pregnancy are going to be in the fallopian tube. So it's right there, close to the uterus, and it's about 95%. You see a nexal mass separate from the ovary, and be aware, sometimes I see a couple of ovarian ectopic pregnancy also, and also look for the ring of fire around the ectopic pregnancy. I will show you. So for that, you have to do color Doppler, or if you have power Doppler, you can use that as well. If you don't have color power Doppler, so that will be a little bit of a limiting factor for you. But most devices nowadays have both those available. You'll see an empty uterine cavity in just a pure ectopic, and then you see free fluid. Those patients that I mentioned who came without any recordable pulse and blood pressure, they had lots of fluid. When I did ultrasound, they had maybe put a liter of fluid inside the abdominal cavity, not just in the pelvic region. It was all over the abdomen, abdominal cavity. So you see a pseudogestational sac, you just see a sac-like structure, and it's pseudogestation, and it doesn't have the double decimal sign and 2 white lines around it. And so therefore, but this is only seen 20%. I wouldn't even worry too much about this. Do you see a live extrauterine pregnancy? I have a great case for you to see. You can see the cardiac activity, and transvaginal can detect ectopic pregnancy in 70% if you don't have much experience. So remember, it is going to be a learning curve here. Sometimes you will diagnose, sometimes you may not. And then once you have lots of experience, I would think you would be, literature says 99%, but I would say 100%. I have never missed an ectopic, so you can diagnose 100% of once you actually have lots of experience doing this. And for abdominal pregnancy, there is something called an abdominal pregnancy. The abdominal probe is very important, because transvaginal probe may not be adequate, because remember, it's a high frequency. So you see about where you are inside the vaginal canal or touching the cervix, you see about 5 centimeters. If it's 7, 10, 15 centimeters away, you're not going to see it. So you must do transabdominal ultrasound. So I hope I've stressed that enough. And also correlate clinically and with lab results. So here you can see this is the case we saw earlier. This is the transvaginal ultrasound. You can see the uterus. You see the empty, endometrial. This endometrium stripe is seen, and there is no evidence of gestational sac or pseudo gestational sac. But just outside, we see an ectopic pregnancy. And when we do, or this is another case, we actually do the color Doppler. And again, color Doppler is kind of contraindicated in normal pregnancy, first trimester, definitely not. It doesn't add any value. But when you have ectopic, you can definitely do that because you can save the fetus or the embryo anyway. So here it is. You can see a ring of fire, which is really essentially lots of blood vessels because this is highly vascular now. And you can see even inside, you can see sliding of the color because this is the ectopic pregnancy. And in this case, this is a C-section scar. So patient will have a scar on their abdomen, anterior abdominal wall. They will give you history of cesarean section previously. And then you can see this is not in the upper region where the implantation should occur over here. It's way down. And you can see this is a dip in here. So this is a C-section ectopic. And of course, when you look at great detail and the uterine cavity and the endometrium, you can see the endometrial stripe. There's no evidence of any embryo gestational sac in here. And when we look at the outside, the posterior to the uterus, you see lots of fluid over here. And this is black is fluid, and that is blood. Okay. So by the way, just to tell you something, most of the times the blood will be anechoic or black, but there will be times when the blood is clotted and it becomes hyperechoic. And then how do we diagnose? Again, as I said, look at the clinical picture, look at everything together, And so, of course, this over here is bowel. You can see bowel. The white is air inside the bowel loop. So be aware that it could be echogenic or bright, not always black. But most of the times, it's going to be black. And then how are we going to tell it's a blood clot? Clinically, you don't see intrauterine pregnancy. You see patients' blood pressures falling. Pulse is feeble. We are thinking this is ectopic. We might see a ring of fire like that. And then how do we know it's blood? The blood is echogenic. You'll see the blood is going to be having acute angles. So we have to look. And that detail you can only see with the transvaginal ultrasound approach. You cannot see anything like that on transabdominal. You only see transvaginally. You will see all that detail. Be aware that once the ova is released, the oocyte is going to come a little bit crumpled and smaller. And if the pregnancy occurs and it supports the pregnancy, it becomes a corpus luteum cyst. So do not confuse corpus luteum with ectopic. This is a very different structure. Here you can see corpus luteum cyst. You can see it's anechoic. Sometimes you see a little blood or some debris inside. But there'll be no evidence of any embryo or a yolk sac, By the way, the yolk sac is the first sign of definitive pregnancy. So it could be inside the uterus, or it could be in an ectopic location, and the yolk sac, and then followed by that, we'll see an embryo with cardiac activity. So here is side by side. We want to look at it again. Which one is ectopic pregnancy? This one? Or is this one? Obviously, this is the one that's ectopic. Looks how similar they look. Because you can see with color Doppler, we can see an embryo in there and has some cardiac activity, so it's lighting with the color. Here, we don't see that, so it's a very different. Both have ring of fire. This is corpus luteum, which is really essentially the structure that just collapsed. Oh, I'm doing something here. So here we have a tip of the day. We can say based on the health, I think everybody's confused. We look at it one more time. We see internal flow here, and here we don't see any flow within. So here's another one, because I think this may be confusing for everybody. So look at this. Let's look at this cases of ectopic pregnancy. You can see that this is empty, right? We don't see any evidence of a gestational sac. There's a gestational sac right here. No evidence of embryo, no yolk sac, nothing. That's good. So now we come over here. We see the bagel sign or the donut sign. Looks like a bagel. Look at this bagel here, or a donut that we have in breakfast sometimes. And inside that, but that is not enough. We look at the evidence of the pregnancy, which is yolk sac inside. So now I'm sure this definitely 100% there's a pregnancy here. Okay. And you see this is a ring of fire in the corpus luteum. So this is not the ectopic. Oh, I'm having some problem with the slides, but I don't know why. Anyway, so we come over here and we see this is the ectopic pregnancy. And you can see very carefully, if you look inside, you see the same bagel sign, you see the uterus, and you see that there is something inside. And you can see cardiac activity. So I'm going to go to the next slide. And here, let's look at it carefully. You can see the embryo. And I hope you can appreciate cardiac activity happening here. And if you look at this particular over here, this is MO tracing. You can do MO through it, and you can actually start seeing MO cardiac activity. But this is a more definitive thing right here. I hope you can appreciate it. So we come here to the heterotopic pregnancy, which may be a new term for you, or but we're gonna look at it in great detail. So heterotopic means patient has intrauterine normal pregnancy, and also at the same time the patient has an ectopic pregnancy. Therefore, it is so important to do transvaginal, because simply being excited about, oh, there's a nice normal looking intrauterine pregnancy, it doesn't rule out the possibility of ectopic pregnancy. And when they are both present, you will notice that that's called condition called heterotopic pregnancy. And so we will be, as you learned in a previous lecture, we're going to identify the intrauterine pregnancy. We see a viable embryo, we see a yolk sac, we see cardiac activity, which will be seen after around 6 weeks. And once you're done with that, then you look for the ectopic pregnancy. And if you do find it, make sure you don't confuse corpus luteum with ectopic. Very different, you know. You must, and also if you see evidence of blood or black, by the way, the black is simply like fluid. We are not 100% sure, but when we clinically put it together, patient, his blood pressure is falling, lots of fluid seen, blood pressure very feeble, you know, patient's was going to shock, then it's hypovolemic shock, then obviously the patient is losing blood somewhere. And so where can it be? It could be ectopic. So just put it all together and it'll make a lot of sense. So here's a case of heterotopic pregnancy, because I can talk about it. But let's see what it would look like. You can see over here, uterus, you see a gestational sac, we see a very tiny embryo, and we also see a yolk sac. This, as I told you, is a definitive sign of pregnancy, okay? So, but if we look outside the uterus, this is the myometrium, and we go out, we see that there is another. We see a bagel sign, looks like a blue bagel, and we see an embryo in there, and we even see, yeah, that's what it seemed like. And so if in the other side, we see same thing. We have, this is a different patient, we see a uterus, we see inside the uterine cavity, we see a gestational sac, we see a yolk sac, the little round thing, and we see an embryo. And outside the uterus, we see something else. We see a bagel sign, right? And we see what? We see another embryo. So this is the ectopic pregnancy. So when you have intrauterine and extrauterine or ectopic, and that would be called heterotopic pregnancy. And fortunately, the incidence is very little. Uh, it's so rare, like one in 30,000. So perhaps I would say if you see that, that would be anomaly almost. And that is on patients who are not receiving IVF treatment. So patients who are receiving IVF treatment, the incidence is much higher. So it's about 1 to 3 per 100. That's almost 3% incidence. That's very, very high. So especially, so take a history, patient said, I'm receiving IVF treatment. Well, then you can suspect patient may have heterotopic pregnancy. Most of the patients that I saw with ruptured ectopic, as I mentioned earlier, came in shock. When I put the probe, this is transabdominal. I don't see the ectopic, but I see lots of fluid. This is bladder. This is the uterus. This is lots of fluid over here. So these are patients who are having a ruptured ectopic. Now we switch to a different topic, which is going to be outside, the ectopic region. So we talk about uterus and identifying the IUD, intrauterine contraceptive device, IUCD. Here you can see intrauterine contraceptive device is going to be bright and echogenic, and it's inside the uterine cavity, and there it should be a normal location. If I told you that it is present here, and that's a problem because that means it's not in a normal location. I can't do it for you. But this is the normal location. It should be inside the endometrial canal, inside the uterine cavity. If it is lying over here, that is highly abnormal. It is perforated. Sometimes it could have slipped down. It's in the cervical canal. That is also abnormal. So we need to remove it. So now we're going to go over some test cases. I don't know if you guys interact with me on this, but I'm going to just show the case. So here's a patient, HCG positive, and we see a uterus, and we see a gestational sac. And is it normal or not? I think at this stage, you should be able to tell me that we divide the uterine, okay, this is the uterus, so we divide it into half. If it's below that, then and it's in a little dip over here. So this obviously is a cesarean scar ectopic pregnancy. And here's another image showing you the same thing. So you should be able to diagnose that very confidently in this stage. So here's the view. The transvaginal ultrasound was performed. I kind of drew the probe in here for you. And this is obviously a sagittal view. So you can see this is a sagittal view. So that means the probe marker is pointing to the ceiling, and you insert the probe. And then as you scan, this is the view that we're getting. This is a sagittal or the mid-longitudinal view of the uterus and the cervix. And so which of the following represents the cul-de-sac? On the pouch of Douglas region, and obviously this is your cervical canal, this is the endometrial canal. So this is where we went in, and there's a bladder. So bladder is obviously anterior, right? So this is going to be posterior, away from it. So this is the cul-de-sac and this is where we would expect the blood to collect, even if it's a small amount, 5 cc, 10 cc. That could be physiological, but it could be also early ectopic rupture. Here's another case. You can see this is a transvaginal ultrasound. So you get familiar with transvaginal images. You can see such a wide field of view. Look at that, really wide, out of 140 degrees. And we can see something outside in the nexal region. And you can tell it's actually like a bagel sign, and we have G1, that's gestation sac 1, G2. So this is not yet ruptured. There's no free fluid over here. but we are seeing, but this patient had empty um, uterine cavity. There was no evidence of embryo or fetus inside, but we do see two separate gestational sacs here. And of course, if you sweep through, you may be able to see a yolk sac, but in this particular view, we don't see that. And so remember, if you see the yolk sac, the round structure like that, with like an outline, that is a definite sign of pregnancy. If you see a yolk sac inside the uterine cavity in a gestational sac, that is the definitive sign of pregnancy. If you see the yolk sac and you see the embryo and you see cardiac activity, that's even better, because now around 6 weeks in transvaginal ultrasound, be able to confirm that the patient has intrauterine pregnancy or ectopic pregnancy, and if the embryo is alive or not. So here's another case. You can see, again, this is not transabdominal, this is transvaginal. See how it's different from transabdominal? In transabdominal, it's going to be like this, like a much wider, and not that wide field of view. And here you can see an ectopic, most probably tubal, and you can see evidence of an embryo in there. So on ultrasound and on a B mode, real-time ultrasound, and even color Doppler, you may be able to see some color, and B mode, you see a flickering action. So that would help you identify this is a live embryo in there. I'm going to show you two shocking cases, which are almost unbelievable. So this patient came in, and the ultrasound was done, HCG positive, pregnancy test is positive, but there was nothing seen in the uterine cavity. So clearly it's ectopic somewhere, and the beta HCG levels are rising. So it is a live pregnancy. There was nothing seen on the transvaginal ultrasound. There was nothing seen in the tubes, nothing in the ovary. So where is the pregnancy? And so somebody said, let's look elsewhere, and they scanned up and they found the patient had a pregnancy in the liver. So remember this, that's also a possibility. There have been reported cases of patient having pregnancy in the spleen, rare, but it can happen. So you can see here, there's a kidney, and inside, this is the liver right here. Inside the liver, you can see vagal sign. We see a gestational sac, and we see an embryo inside. Same thing over here. So keep your eyes open, keep your mind open. That's why I tell you, you cannot just do transvaginal scan. You must do transabdominal. There's no way that you can diagnose this other case also. You cannot diagnose with transvaginal ultrasound. This was done with transabdominal ultrasound. Clearly see the liver. This is the inferior edge of the liver. Nice homogeneous appearance is a diaphragm. And the implantation occurred over here. For some reason, the embryo migrated up and then found a good location and then got implanted into the liver. You can see the yolk sac. I've been talking about yolk sac. Here's your yolk sac. So the question was, what is the structure pointing? What is the arrow pointing to? That is the yolk sac. And remember, yolk sac is a sign of pregnancy. If you see a yolk sac, 100% is pregnancy. It disappears around 13, 14 weeks of gestation. But then we want more than that, because what if there was a pregnancy and didn't survive? Then you see the embryo. You say, I see the embryo. But how do we know the embryo is alive? For that, we go to the cardiac activity. We look for the heart beating inside. So their final thoughts about this is that always obtain relevant clinical history and physical examination, including the lab results when possible. In emergency, as I tell you, a patient comes in shock, they're dying. I don't want to start asking history that time. I'm going to quickly jump to the ultrasound and figure out why is the patient in such a bad shape? Why is the patient pulse not recordable, blood pressure not recordable? This patient is going to hypovolemic shock. They were the bleeding. And so for that time, you obviously want to bypass that. But other than that, we may want to make sure that we obtain proper clinical history for examination, put it all together. It's a full picture. In emergency, as I mentioned, you do quick transabdominal. Again, would I do transvaginal first? No. I want to do my transabdominal. Look at the abdomen, look at the pelvic regions, look at the uterus, look at the cul-de-sac, look at the ovaries, and just a general look. Takes about 2 minutes, and then we quickly go for transvaginal ultrasound. Critical thinking. Think outside the box. As in those cases, the patient's life was saved because somebody thought, HCG is positive, we don't see ectopic, we don't see anything transvaginal, then where is the pregnancy? Let's look elsewhere. And they found it in the liver. One patient, they found the ectopic pregnancy inside the spleen. So be thinking like that. Again, I'm not saying you will find this every day, no. But if you're in a situation you can't solve the problem, then be ready to look elsewhere. Be prepared for anything. It could be anywhere, And finding intrauterine pregnancy does not rule out ectopic. Sometimes we get really excited. We tell the patient, "Oh, you're pregnant," and we say, "I see the baby." Actually, not the baby. We call it embryo. And so we also want to use the right terminology. Be aware that free fluid in the pelvic cavity could be other reasons. There could be small infection, could be physiological fluid. I remember this patient. She just got married 2 months ago. She was a receptionist in the hospital, And what happened is she had abdominal pain and she was rushed in. She was got married a few months ago. And the resident in radiology, by the way, look at the free fluid and say, "Oh, it's a ectopic pregnancy," and sent her for surgery. And they did the surgery and they didn't find any evidence of ectopic. It was just physiological. So please, until you see that ectopic pregnancy, until you see signs of it, until you see a yolk sac or until you see an embryo and the cardiac activity, please do not diagnose ectopic. You must be able to confirm it. You can't just look at fluid in there and make a diagnosis. It's just not the right thing to do. If once diagnosed, a patient unstable, rush emergently, start fluids, and arrange blood. And then remember that really ectopic could be in the abdominal cavity, liver, or spleen. I didn't mention spleen here, but there was a case reported in literature. You can check it out. You can type in Google, it says spleen pregnancy. It's there. So one thing, as we are attempting to learn ultrasound and perform ultrasound and write reports and talk with each other or discuss cases, make sure we are following the latest consensus and the agreements by the radiologist team from around the world. And they created something called a lexicon. And these are just some of the few that they came through. But you must use the right terminology. So we call it embryo or fetus, right? Don't call it fetal pole. There's no pole. It's an embryo or fetus. So cardiac activity or cardiac motion, we don't say heartbeat, heart motion. That's not to be used. We say cardiac activity, cardiac motion instead of live, living, viable. That is obsolete, and we're not going to do that. And then first trimester ultrasound, that is actually, we don't call it viability scan. There's nothing viable, So don't do all that. Just use the proper lexicon, the terms set together by a group of radiologists who put it together, who are heavily dedicated to performing ultrasound and OB ultrasound as well. So make sure we use the right kind of terminology. For failure, we just call pregnancy loss, EPL, so an embryonic pregnancy. We used to use blighted ovum in the past, but we don't use that anymore. We call it an embryonic pregnancy. So pseudogestational sac or pseudo-sac, as I mentioned earlier, you'll see a sac-like structure. It looks like a gestational sac, but it's not. We call it intracavitary fluid now. It's fluid, black is fluid. So we're calling it endometrial cavity fluid or intracavitary fluid. And that's the term we will use. Cesarean scar ectopic pregnancy. We won't call it cesarean pregnancy because somebody may think this is normal. It's not normal, it is ectopic. So we want to use the full term and call it cesarean scar ectopic pregnancy. Cervical ectopic pregnancy, IUP, intrauterine pregnancy, interstitial ectopic pregnancy. So make sure we use the right terminology, and when you write reports, make sure and you can print this out and have it available right in front of you, especially when you're writing reports, so that you can. I'm going to have a question Q&A session, but before that, I'll just go through the rest of the slides so we end this here. But here's some bonus content. So I would highly recommend for you trying to pursue this. I actually did a webinar some time ago, and this is a link to it. You can definitely type this link and be able to access this. And also, I will provide everybody a PDF version of this entire presentation. So you have the slides, you can print them, you do whatever you want. You will also get a video of this lecture, so you can listen to it again and again. Or if you have doubts on a certain topic, and then jump to it and look at it. And definitely look at this webinar, because this webinar is also, I think, 1 hour long and covers things that have been already covered in the past for you, but this will consolidate your concepts. And this is the highly recommended lexicon for the first trimester ultrasound by the Society of Radiologists in Ultrasound Consensus Conference recommendation for 2024. So the good thing is, normally we're looking at these things that are like 10, 12 years old, but this is 2024. So we want to follow the latest standards, which are standard of care, standard of terminology. We want to use the correct terminology as we are learning ultrasound. Thank you very much. And now we will go to our other things, few slides here. Basically, volunteer with us. We love volunteers, and what you do as you're learning ultrasound and you encounter cases, you may share those things with us and follow us on social media and get certified. So thank you. And now I'm going to switch the slide back to the Q questions. All right, thank you.
Thank you, Vic, so much. It's been such a great presentation. Thank you so much for sharing your expertise. I see one question came in. What is the recommended aseptic cleaning solution for the transvaginal probe?
Yeah, the common one is the glutaraldehyde, as I mentioned in there on the slide. But the best thing is you must contact your ultrasound manufacturer, because they have epoxies that they use for their for putting the probe together. So they have tested the transducer, which works best. So I would suggest highly that you actually contact a device manufacturer who made the transducer, and they will guide you which is the recommended cleaning solution. Because if you use something other than that, it's possible it may damage your transducer or may even void your warranty. So we don't want bad things to happen. But definitely do not use alcohol, please. Alcohol is not to be used on transducer. It is not approved disinfection agent, and it's not to be used. It's also going to damage your transducer. So I would highly recommend, even though glutaraldehyde is highly recommended, but I would go back to the manufacturer and they will tell you. If you bought from device of some company, we will tell you what we recommend for using for disinfection. But don't just wipe it. There are wipes also available. I think highly controversial. How can you disinfect a probe in just 10 seconds? You just cannot. This is a high-level disinfection process, and so you must undergo the procedure. The chemical and the device manufacturer will tell you how many minutes it must be submerged in the chemical. We do not want to transmit infection from one patient to the other. That is not acceptable. Thank you.
Thank you, Vic. I don't see any questions submitted via chat or Q&A, but feel free to raise your hand and we can definitely unmute you and ask your questions while we have Vic with us. This was a lot of information, so we definitely understand if you need a little bit more time to process, but we're here for any questions you have.
The way I designed this presentation is that it's got everything that you would possibly need. So after reviewing it and after reviewing the review material and then the additional video, you have everything really, that you want to do transfer successfully. So good luck to all, and thank you for attending. And it was a pleasure presenting. And if any questions come up later on, then definitely shoot an email, and we'll be happy to respond.
Definitely let us know how we can help, and feel free to email us. We'll send you all of the presentation recording and then the copy of the presentation for your reference. And if you review and have more questions, just feel free to email us back, and we'll get in touch with you. Thank you. Thank you, Vic, and thank you everyone for taking their time to join us.
Thanks, Daria and Vic, for coordinating. We'll stay on for a couple of more minutes if anybody does have any questions. But if you don't have any questions, you can feel free to leave. But if you do have any questions, we can stay on for a few more minutes to answer those questions. And yeah, thank you guys so much for trusting us with your POCUS learning journey. And we'll definitely be here to continue to support you.